Everyone, and thank you for joining us for today's masterclass. Dr. Vijay Limai from the Natural Resource Defense Council and myself will share some perspectives on how economic valuation could improve our understanding of the health impacts and solutions related to extreme heat exposures. The need for such economic assessments was strongly identified by participants in the first GHIN meeting in Hong Kong. We will try to provide snippets of what we consider to be useful tools and information for practitioners interested in applying economic valuation in their public health work. There will be two presentations in the lecture today. I will briefly talk about the challenges in using economic valuation tools to better capture the human health implications of rising global temperatures. Then I will provide a framework specifically aimed at estimating the direct health costs associated with exposure to ambient heat. Both of us will talk about case studies based on the application of this framework, and Dr. Limai will conclude with an overview of using economic valuation to solutions aimed at reducing health costs related to heat exposures. The reported estimates of economic loss associated with extreme weather events nationally and globally are huge. The National Oceanic and Atmospheric Administration catalogs weather and climate disasters each year that result in economic losses to society in excess of billions of dollars each. The graphic on the left shows that the US was impacted by 14 such separate billion-dollar disasters in 2019. To put such estimates in the larger context, the total cost of US billion-dollar disasters from 2015 to 2019 has exceeded $525 billion. The graphic on the right indicates the growing societal costs of natural disasters globally from 1980 to present. While these total economic estimates of loss are staggering, what is worrying is the fact that less than one-third of these losses related to extreme events are covered by insurance, the lack of which is mostly observed in poor countries in Asia and Africa. It is worth noting that none of these estimates actually take into account the adverse health impacts associated with these extreme events. The challenges in attributing health consequences to extreme events, like hurricanes, wildfires, and flooding, and/or variability in meteorological factors like temperature, precipitation, and humidity, likely limit the economic valuation of these adverse health impacts. As a result, we are grossly underestimating the human consequences of these extreme events for the most vulnerable sections of the society, for whom loss of productive assets have welfare consequences that lasts across generations. So in this context, economic valuation of health impacts related to extreme heat assume great significance. Monetized values of the health damages associated with extreme heat provides an additional metric to convey the health burden from extreme heat exposure to decision makers formulating health policies and allocating budgets for health prevention efforts. Economic valuations can be designed such that healthcare costs can be compared across different perspectives: individual patients, providers of care, employers who participate in health insurance programs, government agencies who provide social support for vulnerable populations, and the society at large. And estimates of these health damages also become inputs in assessing cost effectiveness of potential solutions that aim to reduce adverse health consequences, as health costs of inaction are compared against the counterfactual where the new solution is implemented. The distinction that is made between the direct and indirect health impacts of heat waves have implications on economic valuation methodologies as well. So the link between extreme heat and a range of chronic diseases like cardiovascular, respiratory, renal outcomes, as well as those related to injuries and heat exhaustion, are well established in the literature. The direct causal pathway linking these health outcomes to extreme heat makes it easier to attribute incidence of outcomes to daily fluctuations in ambient temperature. As a result, it is relatively straightforward to conduct cost of illness type economic evaluations for these direct impacts of heat exposure. I will talk about this in more detail later in the presentation. Now, the indirect health impacts associated with heat pose a greater methodological challenge. First, the causal pathways can often be more complicated with a number of intermediate factors in between heat exposure and the health outcome of interest. For example, extreme heat in conjunction with precipitation lead to changes in ecosystems which impacts the habitats and life cycles of disease vectors and hosts that affect the geographic spread and cases of vector-borne disease. The growing literature on the impacts of extreme heat on preterm birth points to the potential time lag between exposures to heat and outcomes of interest, for example, the development delays among premature babies. Economic valuation of such outcomes that manifest itself with long temporal lags can be challenging. Nonetheless, I wanted to briefly describe the application of economic principles in assessing the impacts of temperature on worker productivity and nutrition. The Environmental Protection Agency in the US coordinates the Climate Change Impacts and Risk Analysis Project, CIRA. The project aims at estimating the economic consequence of significant global action to reduce greenhouse gas emissions on multiple US sectors in the future, compared to a scenario in which current emissions continue to grow. Now, extreme summertime temperatures due to climate change affect labor in many ways, particularly workers' health, safety, and productivity. When exposed to high temperatures, workers may fall sick and/or take more frequent breaks or have to stop work entirely, resulting in lower overall labor capacity. This graphic shows that the majority of the country would experience decrease in labor hours due to extreme heat in the future. In 2100, parts of the Southwest and Florida are estimated to experience a decrease in hours worked for high-risk industries that could range from 5 to 7%. Although the impacts vary by region, only a limited number of counties are projected to experience increases in labor hours. So this analysis estimated the cost of the projected losses in labor hours based on the Bureau of Labor Statistics estimated average wage in 2005, adjusted to 2100 based on the projected change in gross domestic product per capita. So in this graphic, the reference state of inaction is represented in red and the counterfactual of global greenhouse gas mitigation in blue. Effective mitigation is projected to prevent the loss of approximately 360 million labor hours across the workforce in 2050, saving nearly $18 billion in wages. This, in 2100, increases to prevention of loss of nearly 1.2 billion labor hours and $110 billion in wages, as compared to the reference period. This schematic is borrowed from an article in the Annual Review of Public Health that shows the potential pathways through which climate change can impact food security and nutritional status. I have chosen one pathway shown by these red bars to highlight how an interdisciplinary modeling approach linking climate science, agricultural production, prices of agricultural products, and health could be combined to assess the impact of rising temperatures on availability and nutritional content of staple foods. So starting at the top, a physical climate system model would produce temperature, other environmental conditions, and CO2 in the future based on a greenhouse gas emission scenario. These would then become inputs to an agronomic model to determine crop yield and its nutritional content. An economic model would follow, which would then determine the prices of these commodities, as well as the ability of individuals to purchase and consume these products. And finally, a health impact model would determine the nutritional status given the consumption patterns previously modeled. While highly stylized, this provides an idea behind the conceptualization of integrated assessment type models, IAMs, that tries to link select features of the environment, economy, and society into one consistent modeling framework. In economics parlance, this framework might be called computable general equilibrium models. While the devil's in the details of the specification of each of the model component, it is important to note how the economic modeling of commodity prices is used as an intermediate step in assessing the impacts of extreme heat on nutritional status in the future. So we shall pivot back to the issue of estimating the health costs associated with exposure to extreme heat, the direct health costs. I will mainly focus on a framework that can guide you in deriving the cost of illness attributable to extreme heat, a question that some of you had actually sent us while registering for the class. So the first step involves the decision of the health outcome to consider, whether to assess the heat impacts on mortality, morbidity, loss of productivity associated with illness of interest. And the next step is to decide on the case definition. One could potentially use the International Classification of Disease Codes for hypothermia as the case definition for heat-related impacts. The advantage of doing this is that routine surveillance could be conducted using this approach to track changing disease burden across seasons as well as conduct syndromic surveillance. The disadvantage is that we know that heat directly impacts individuals with a range of other comorbidities, and relying solely on the heat-related clinical codes would produce an underestimate of the health burden associated with heat. As an example, the graphic on the left shows an annual average of 702 deaths coded as heat-related illness in the vital statistic records for the years 2004 to 2018 in the United States. The graphic on the right is a study published in Lancet that considered all-cause mortality for the US for 1985 to 2009 and estimated an annual average of around 3,000 excess deaths attributable to extreme heat. Thus, the epidemiologic approach one uses to calculate the health burden will have implications in the subsequent derivations of the cost estimates. As far as valuing mortality is concerned, you may be aware of the term value of statistical life, or VSL in short. A quick explanation of the concept of VSL could possibly be new and useful. It is not the value that the individual, the society, or the government places on averting an identified death with certainty. The term statistical refers to a small change in the chance of dying, and the VSL reflects an individual's willingness to exchange money for that change in risk. So, for example, if an individual is willing to pay $300 for a reduction in risk of 1 in 10,000, then the VSL for that individual is estimated to be $3 million. Now, these estimates of VSL are highly context specific. So, for example, VSL estimates for the same population can vary depending on the kind of health outcome being assessed. Should, for instance, a VSL that is measured in the context of work-related risks be applied to a context of diet-related risks to health? A rich person or community may be more willing to forego a certain sum of money if promised a reduction in risk compared to a person or community with lesser income. Similarly, the risk tolerance of a young adult might be very different to an older adult, with implications on what the appropriate VSL may be. Since it's impossible to incorporate all these nuances in estimating VSL for each individual uniquely, it is convention to use a single metric as a representative of the entire population. The value of mortality risk reductions is relatively well studied in high-income developed countries. This table shows VSL values that are used in the United States. Note how the estimates used by EPA, the $7.4 million, differ from the ones used by the Health and Human Services, which is $9.3 million, in regulatory impact analysis. In comparison, the representative VSL estimate for OECD countries, it's much smaller at about $3 million. Now, the reference provided in the previous slide is a useful resource for information on country-specific VSL estimates. For example, based on the estimate provided in that guidance document, the population average VSL for India is around $318,000, that of Rwanda is $50,000, and that of Turkey is about $2.8 million. The estimates of individual willingness to pay ideally would be used to value morbidity health reductions as well, as was done in the case of mortality. However, given the number and diversity of possible illnesses and injuries, it's difficult to find studies that are available for the specific health effects that you're interested in. As an alternative, often medical records would provide information on the financial transactions that took place between the individual and the healthcare provider for services from physicians and other healthcare providers, medication, hospital stays, and so on. In some situations, these payments could be paid out of pocket by the ill individual, and in some cases, paid in part or whole by the health insurance company. In this context, it's worth mentioning about the two metrics of health-adjusted life years, the quality-adjusted life years and the disability-adjusted life years. The QALY is a non-monetary measure that integrates the duration and severity of various health conditions. QALYs are generally derived by multiplying the amount of time an individual spends in a health state by a measure of the associated health-related quality of life. One, it's determined for a particular health state, the HRQL, is then multiplied by the duration of that state to estimate the associated QALYs. In contrast to the QALY, the proponents of DALY, the disability-adjusted life years, choose to attach estimates of the health-related quality of life to specific diseases rather than to health status. In part, this was done for pragmatic reasons, given the difficulties of collecting comparable primary data from the vast number of countries for which a global burden of disease is calculated. However, I'm not aware of any DALY or QALY estimates developed to examine the direct health impacts of heat. And the indirect costs associated with lost productivity may stem from absence from work or from decreased productivity while at work. Productivity losses may also include the opportunity cost of providing care for a sick family member, decrease in unpaid work such as household services, or volunteer efforts. For the US, the cited article uses the gross human capital approach to provide age category specific estimates of annual and lifetime productivity by age and sex, including both market productivity, which is typically modeled using wage earnings, and non-market productivity, which is typically used using valuation of household services. One can use this table in conjunction with available information on absenteeism, days hospitalized, or undergoing treatment to estimate the economic loss due to lost productivity. I would quickly present a case study that applies this framework. And this study was led by Dr. Yang Liu when she was a doctoral student in the University of Minnesota. We conducted a comprehensive economic assessment of the health impacts due to cold and hot temperatures in the city of Minneapolis in the US. Minneapolis is located in the northern part of the country with a population of about 3 million. We use daily temperature data from the local National Weather Service stations and daily data on all causes of deaths, emergency department visits, and hospital admissions for this particular study. We used a distributed lag nonlinear model framework to assess the excess health outcomes attributable to the temperature extremes. So rather than using pre-post health information around a heat or a cold wave, we looked at daily data during the summer and winter months to estimate the relationship between temperature change on either end of the temperature distribution and health outcomes. So in each of the panels, the red line indicates the mortality relationship, the blue indicates emergency visits, and the green indicates hospital admissions. The bold line indicates statistical significance, while the dotted sections indicate lack of statistical significance. And the top left panel represents the overall population, while the others are for specific age groups. We observed that the mortality impacts for heat were only significant for the seniors, while the emergency visits and hospitalizations due to heat were significant for those in the 0 to 19-year age group. The advantage of using the statistical framework is that we could estimate the additional number of cases attributable to heat and cold across the age groups. The panels on the left show the results for cold exposure, while the panel on the right shows the results for heat exposure. Overall, we see a larger attributable burden for cold-related health outcomes than heat, which is expected given the climate of the region. For heat, we observed a much larger proportion of morbidity in the 0 to 19-year age group, indicated by the blue and green bars, while that for mortality was highest among the seniors, which is indicated by the red bar. Interestingly, we observed a higher proportion of excess cases when the temperatures were in the moderate and extreme categories, defined as temperatures above the 70th percentile for heat and less than 30th percentile for cold, compared to the extreme category, which was defined as temperatures above the 95th percentile for heat and less than 5th percentile for cold. This has potential implications for calibration of when temperature-related health alerts are issued. And so this table brings together the attributable cases of mortality and morbidity and pairs it with the relevant economic indicators to derive the monetized value of the health burden. So the left two columns indicate the health outcomes and the age groups. The two columns in the middle indicate excess cases and costs associated with cold temperature. The two columns in the right indicate those for heat. The excess cases that you see are the numbers taken from the graphic displayed in the previous slide. So if you look at the highlighted row, excess mortality estimates for the 65 and above age group were paired with the EPA estimate of VSL to obtain $8.1 billion of health costs associated with cold temperature and $1.17 billion of health costs associated with heat. Given the high estimates of VSL, the mortality costs and cost of illness studies like this will be much larger than the estimates one derives for costs of morbidity. The estimates of morbidity with heat were similarly paired with the reported financial costs of providing medical care in the emergency room and for hospitalizations. Since only the 0 to 19-year age group showed statistically significant relationships with heat, we calculated economic estimates for that age group only. These amounted to about $1.4 million and $1.5 million per year for emergency room visits and hospitalizations respectively. And so overall, our estimates indicate a total direct health cost attributed to cold and hot temperatures in the city of Minneapolis alone to be $8.2 billion and $1.17 billion a year, respectively. And to conclude, such cost of illness studies provide a benchmark to compare the adverse economic impacts to society from extreme heat with other health outcomes. The age group specific estimates of the burden and cost can inform appropriate prevention actions. For example, if health cost minimization is a desired objective of an agency, the focus of preventive actions could be on reducing heat-related mortality among the seniors. On the other hand, an objective of reducing the overall number of adverse heat-related outcomes might lead to a greater emphasis on preventing heat-related illness among the younger age group. The health cost estimates can now become important inputs for the cost-effective analysis of potential health interventions that could help avoid some of these adverse consequences. This framework is also flexible and can incorporate future projections of healthcare costs associated with increased temperature and climate change. One can potentially use the exposure response functions in conjunction with future temperature and demographic projections and appropriate methods of discounting future healthcare costs. With that, I'll end. Thank you so much for your attention, and I'll take questions.